So what we're talking about here is a Medtronic O-arm with what we call a stealth navigation unit. What this offers UHC and our patients is a couple of things. Number one, I use it mainly for placing instrumentation in the spine. The O-arm enables me to do that more accurately in a safer environment for the operating room staff. And it gives us a degree of confidence, and when we take that patient out of the room, that their instrumentation is where we want it to be. That's important if a patient has a post-operative problem or specific post-operative complaints. I know that it's not from the instrumentation because when they leave the room, it's where I want it to be. And if it needs to be revised, there's no reason to bring the patient for a second surgery. The patient's already asleep. If something is not right, we can fix it right there. The O-arm itself is a pretty big unit. It's got several pieces. The first is the actual imaging part. What it does for us is give 3D imaging of the spine, and that's inclusive of the instrumentation that we put in it. So a patient undergoing, say, a lumbar fusion would come into the room, undergo anesthesia, be put asleep. We'd position them on the operating table. At that point, we put a reference marker on the patient, and usually that's in the hip, and then we bring the O-arm in. We have trained people that do that, and we take images of the patient's spine. Those images are downloaded to a navigation unit, which is called the stealth navigation, and we review those films, and from that we can determine screw size and exactly how we're going to perform the surgery. The stealth communicates with our instruments, so for example, I can take any one of the navigation instruments, put it on a part of the patient's spine and look at the screen and see where I am. And that's without active radiation. So once we expose the area of the spine, I then use the stealth navigation, the navigated instruments to place the screws. I'm looking at a screen and the patient while I'm doing this and seeing the screw go into its target and its placement. Once I'm done placing all the instrumentation, and we're basically done with the procedure, at least the instrumentation, we bring the stealth back in the room and take pictures to verify that instrumentation is where I want it. What this gives our patients is instrumentation that's placed as accurate as you can do it. I believe the literature shows it's about 98–99% accurate, as opposed to the human hand, which an experienced hand is not that accurate in terms, it does not approach the O-arm, but I think 90–95% or so is what your experienced surgeon can do. It just gives you a degree of accuracy further than a very good surgeon. And again, like I said, the instrumentation is placed where you want it. When the patient leaves the room, there's no need for a revision.